that now. Okay, we are now recording. So welcome everybody to the inaugural Speak Up Delaware. I'm pretty excited about this because I think it's important that Delawareans speak up and their voice is heard. I think too many people are too concerned about retribution or too concerned about maybe what other people may think. And I think we should overcome that and not live in the world of fear, but speak up our thoughts and speak up our convictions. And we've got our first guest here tonight, and that is none other than, of course, Dr. Chris Cassells. Dr. Chris Cassells, in my mind, is perhaps the most respected and talented orthopedic doctor in all of Delaware, if not the entire Mid-Atlantic region. I know he's a humble guy. I do know that about Chris, but nonetheless, Dr. Casscells is extremely talented and has had his own practice for many years. And he is going to share a little bit about his background here as we get started. And then from there, we're going to talk Delaware, and we're going to talk about COVID-19. It's really important that we come to some realities and some truths about these numbers that we keep hearing. And Dr. Cassells, I think, has some very insightful information that he is willing to share with all of us, that in turn we can share to our communities and perhaps even throughout the state and perhaps even the nation. I think it's that very profound. So if you would, let's all welcome Dr. Chris Cassells. So Doctor, welcome, and thanks for being here.
Thank you, Rob. It's very much a privilege to be here. You had requested a little quick bio. I'm a Delaware native. I was born and raised, I was born about 1.5 miles to 2 miles in one direction from my current house, and was raised about 2 miles in the other direction. So I spent most of my career operating in an operating room that was about 30 yards away from the maternity ward where I was born. So I haven't gotten very far in life. So I left Delaware after Tower Hill School and went to Yale University, and then from there got my medical degree and did a lot of research at the University of Virginia. Then went back to Yale, did both surgical and orthopedic surgical training there, and then came back to Delaware in 1986 and have been it was in private practice orthopedic surgery until the end of December when I fortuitously retired. While at Yale, I did develop an interest in public health and epidemiology because I was mentored by a man named Dr. George Silver, who mentored both me and my older brother. My brother was actually a fairly famous cardiologist who also dabbled extensively in epidemiology and was at NIH with Dr. Fauci back in the day. So it's been an interest of mine for a long time, an interest of mine through my presidency of the Delaware Academy of Medicine, and then for some time now, probably about 11 years, I've been writing pieces about healthcare policy, and so that's sort of what brings me to this position now, and very much fascinated by the recent trends and some of the reactions to this novel virus. We call it a novel virus because it has some new and different characteristics, and yet fundamentally we're treating it the same way. We're treating it with the same tools that we developed over 100 years ago for polio, tuberculosis, and venereal disease. And as you might well guess, the virus isn't acting the way we would expect. So we like to say that a battle plan changes the minute the first shot is fired. And what we're currently doing now is essentially attacking the enemy where we think the enemy was 3 weeks ago.
When you say enemy, doctor, you're talking about the virus itself, COVID-19.
I'm talking about the virus itself. Yeah, we're sort of constantly behind the 8 ball because we're not staying current
Well,
with.
before we go into that, I want to here before we get into the details specifically as you're about to go into, I want to kind of talk about it for real quick, the bigger picture from what I understand. Correct me if I'm wrong on this, doctor. And that is, look, this all originated from China. We know that. That's a fact. We also know that they were not transparent. They were not truthful in their numbers. We know that as a fact. We also know as a fact that on January the 14th, the WHO tweeted that they were agreeing with China that this pandemic, well, at that time, it was not a pandemic, I should say, but this virus back on January the 14th, according to the WHO, was not transferable from person to person. That's a fact. They're on record. I've posted about that in the past. So that's kind of a foundation, if you would. Moving forward a couple of weeks, our president saw what was coming, concerned about that, cut off travel, okay, coming into our country from China, other than, of course, U.S. citizens. But other than that, he shut down all travel coming into the United States from China. And the whole focus and the whole narrative back in latter part of January into February and early part of March, from a national perspective, was all about flattening of the curve. Okay. And as a layman guy, meaning clueless about medicine and all that, like most people are, we are just regular, people. What I interpreted that as to be is when you want to flatten and need to flatten the curve, it's all about not having too many patients that are going to overrun the healthcare industry, be it hospitals or alike. And so the whole goal was, we as Americans were told to stay at home and do our part to help flatten the curve as to not overrun the healthcare facilities. That was step number one. Step number two, there was concern about not having enough respirators. Okay, that was the second element to this. We did not have enough respirators. There were going to be several million people infected, if not more than a million, or many, many hundreds of thousands of people dying. That was the early predictions. Am I correct on that, doctor?
Yeah.
And so the whole goal there, again, we did not want to overrun our system and not have enough ventilators, okay, that were going to be able to care for those that were in the greatest of need. So we in my mind, we accomplished that goal. I'm not aware of any hospitals in the entire country, maybe outside of New York City, perhaps, but certainly none in here in Delaware, that not one hospital in the state of Delaware was overran by patients that they could not handle the load of patients. Could you tell me if I'm accurate in that statement?
Yeah, that's pretty much a good synopsis, a good summary of what we've been through.
So moving from there, and therefore, were there any cases that you're aware of in Delaware, okay, that we did not have enough ventilators for those that had a need for it? Are you aware of any patients anywhere in Delaware? I'm not aware of anybody in the country, but we're talking Delaware. So you tell me if I'm wrong. Are you aware of any patient in Delaware that has never had an opportunity to be on a ventilator who needed to be on a ventilator?
No, Delaware has been essentially exporting ventilators to places where there is a fear of another outbreak going on. We never came even close to a ventilator shortage.
Okay, so we flattened the curve. We did not overrun our hospitals, and we had enough ventilators to go around. Is that an accurate statement?
That's true. There are some fine points about why that actually happened, but you're absolutely right.
Okay, so moving forward, I know about 3 weeks ago, give or take, the president intentionally put the focus on the governors, because as our Constitution is written, right, it is truly 50 governors that are in charge of their states. The feds created some guidelines, okay, as we learned more about this pandemic, really amongst ourselves, because again, we were not getting the pure and accurate information coming from China, and for that matter, even the WHO. And so as we learned ourselves as Americans, we learned that what to do and how to do it. Therefore, the focus was on the states in reference to distributing the PPPs, not the PPPs, but the PPEs, excuse me, to the various locations, to the various resources, and throughout the network within each of the 50 states. So are you aware of any significant issues that we ever had, that we've had in Delaware with regard to not having enough PPEs, whereas somebody was affected in a negative way because of a lack of PPEs? Can we talk a little bit about the PPEs?
Well, the personal protection equipment, it basically consists of gloves and masks. And there was fear in the frontline workers that there wouldn't be enough to go around, certainly not of the ones that are graded, the 95 grade, which is an industrial grade of filtration. It didn't actually happen in Delaware like it did a lot of places. In a lot of places, what actually happened was there was a panic and people began hoarding things like that. But I'm not aware of any problem with that here, except for a solitary nurse in the Christiana system who quit her job because she felt that she was not being given enough personal protection equipment, and she was quite vocal for a short while. But I didn't see that actually pan out to any great extent. You know, as somebody who just cleared out his office, and you know, I was handing out stuff to everybody, to whether it be hand sanitizer or face masks or whatever, and there really just didn't seem to be that much of a demand for it. Part of it was that, at least here in Delaware, in the beginning parts, we did make it clear to people that a face mask does not protect you from the virus. It protects other people around you from you giving them the virus. So we didn't quite have the run on them here in Delaware that happened in some other areas. In some of the denser metropolitan areas, especially those areas with large Chinese populations, where the Asian population is very much accustomed to wearing face masks in public. So there was a bit of a panic and a run on them in areas like Manhattan. But I think that's been solved now with repurposing of some manufacturing facilities, and frankly, by a lot of, you know, industrious people. My wife got sat down at her sewing machine and started making face masks, and carried them down to the hospital where she'd recently had surgery, and the staff was very grateful for them. That was down in Florida. They were suffering a bit of a shortage there, but it hasn't had that too big an impact here in Delaware, except for, as I said, that one very vocal nurse who felt that the intensive care workers were not being adequately protected.
Well, I appreciate you for sharing that. So talk to us again, Doctor. Talk to us about your analysis of what's been going on, the context of where we are as it relates to, I mean, based on what you've just said, what are we doing? I mean, I want your analysis as a healthcare professional for decades, highly respected. What's your take on what's going on?
Well,
and be honest and be blunt.
Okay. In the overarching review of this, what you'll find is that some very, very vocal people early on basically poo-pooed the thing and said, "This is nothing. Go to your Chinese New Year's celebrations. Go watch the fireworks. Go out, enjoy, spend money." This was the mayor of New York City and many other people. Dr. Fauci himself, as of the end of February, was saying this is nothing. It's we have it on good, reliable information from the WHO, who was in fact not telling the truth, that this isn't going to be any big deal. So the response to the early evidence of this being a very worrisome virus was unfortunately too little too late. And then, of course, there was the necessary overreaction to it, and that's been well documented. There's been just, there's basically panic, and everybody started hoarding things, and that made the problems a lot worse. And now then it wrecked the economy. Just to go properly on the record, I went back and I reviewed what I was asked to write about, and we published on March 15th of this year out of Cesar Rodney Institute my take on the whole thing. And I went back and I've reviewed it, and I wouldn't change a word of what I wrote. What I wrote was, don't rush the emergency rooms, don't rush the hospitals, don't concentrate the virus in these small areas and overwhelm our health system. There's not much value in wearing a face mask at this point unless you yourself are sick. And I said, and wash your hands, and wash them a lot, and use some hand sanitizer. You've got to carry it around with you. Go get some Purell somewhere, and stop kissy facing your friends at cocktail parties. And I think I stand by all those things to this day. The number of infections has been very, very small. The number of deaths is very, very small. There's two baked-in problems. I'll address the first one that you mentioned initially. The WHO and China basically created this as a pandemic by not telling people about it. So those two sins that you put out there were really the same one. They're pretty much the same thing. They hid it, and they hid it from the rest of the world, and they restricted travel inside China, but they allowed the Chinese out of the country, and then they lied and didn't tell us that it had jumped from animal to human and human to human, and for that there rightfully should be some serious action taken with respect to trusting both the World Health Organization and the Chinese infrastructure, the Communist Party there. The second thing that happened in this country was the shutdown did mitigate an outbreak, but all of the computer models were wrong. Not some of them wrong, all of them wrong. And they were wrong by factors of 10, of 100. They were way, way, way wrong. And what that tells you is that they are using the wrong input into the model. They're looking at the wrong things. They're not making the correct calculations. When all the models are wrong, there's something fundamentally wrong with your knowledge base. And then there's a subsequent failure of not recognizing exactly what this virus was doing. And so when we flatten the curve, you don't actually change the number of people who get infected. What you do is you change the date at which they become infected. So we changed the dates, and that had the net effect of buying us a little time. But then the other side of that is at what cost, and of course the economic damage is catastrophic. And it's not just catastrophic to the overall economy. I've been saying this for a couple of weeks now, based upon calculations of the loss of revenue to the University of Virginia health system, where I sit on the Health Foundation board. They came to the understanding several weeks ago that they were hemorrhaging $3 million a day. If you do the math, that translates to Christiana Hospital hemorrhaging $5 million a day. The hospital bed capacity has been between 100% and 105% for the last 20 years. It is currently down between 13 and 15%. The hospital is empty.
I gotta stop you right there, doctor. So what you're saying is that normally a historical context, the capacity, meaning the people in the hospital, patients in the hospital, typically is, you were saying 100 to 105%, basically at capacity, right?
That's almost always the case. We have
Always the case.
on our physician portal, when we log into to the hospital's website, it gives us the daily bed count. So I have been looking at this number on a daily basis for, well, ever since we computerized, which was 20 to 25 years ago.
So right now in Delaware, or now was that number you mentioned 13%? Is that Christiana Hospital, or is that throughout the entire state?
I think that's Christiana Hospital.
Which is
and Christiana today, just this afternoon, confirmed my number and admitted that they are losing approximately $5 million a day. And that's because of the cessation of the normal practice of medicine. We're no longer doing knee replacements, hip replacements. We're no longer doing cardiac catheterization. All elective surgery, all elective hospital work stopped as of about 8 weeks ago. So, you know, at some point or another, now Christiana probably won't fail because it's a hospital of last resort, but certainly smaller hospitals are going to close. Wow. They can't sustain that kind of an economic hit.
So I'm not sure how to respond to that, because we don't hear this. We don't hear the fact that, you know, Christiana Hospital, as an example, is only running 13% of their capacity.
Well, it was a request and subsequently an order by the governor to stop anything that's not essential. Well, you know, when you start out shutting things down, an odd sort of thing happens. Your actual death rate from other stuff goes down. That's partly because there are fewer people out and about. There are fewer automobile accidents. Mm-hmm. There are a lot of things. There are fewer accidental deaths because people just aren't out and around. But the delay in the normal treatment of diseases, kidney disease, heart disease, pulmonary disease, and so forth, the delay in the usual treatment, the delay in diagnosis of cancer, in monitoring of recurrent breast and ovarian cancer in people who've been treated, those delays start to mount up very, very quickly. And now all of a sudden we are seeing that death rate catch up. We're starting to see that collection of deaths. Right now, the data is largely distorted because Health and Human Services and CMS, which are the government's health agencies, they pushed very hard to heighten the response to the COVID-19 diagnosis. And they did this by allowing a separate coding for the coronavirus. There's one code, which is U07.1, which means test proven coronavirus infection. Then they added a second code, which is U07.2, and that means possibly related to coronavirus, but untested and certainly unproven, but possibly related. And what they did was they allowed that both of those codes could be used to get the same reimbursement. And the reimbursement, when you attach those codes to a hospital admission, changes the amount the hospital receives by $30,000. So obviously there's a very, very strong incentive there, especially when you're under financial pressure, to add the coronavirus code to the list of codes. So much so that patient comes in, chronic, long-standing heart disease, comes in congestive heart failure, Their lungs filled with fluid because they're in congestive heart failure. They probably weren't going to live out this year anyway, but they die. And then put on the chart is U07.2. All of a sudden, the hospital gets paid an additional $30,000 because it's possibly related to coronavirus. So you see that there's a distortion of the data that happens when you do that sort of thing. And like most things, it was probably intended well, but the law of unintended consequences is pretty doggone reliable.
So what you're saying is that we here in Delaware, okay, I know you looked at the numbers probably earlier today, as did I, but there's over 5,000 cases, positive cases, right, reported now here in Delaware. Unless we're not at 6,000, are we? Did I miss that, Doctor?
I had that up a minute ago. We have reported now 7,223 positive cases.
So with that being said, over 7,000 reported cases, based on what you just said and what you just shared, you are certain that 100% of those 7,200 people don't necessarily have it.
Oh, I'm quite convinced that many of them don't.
Many of them do not have it in your
many of them do not. They have other diseases that and they're just being coded as possibly related. And that's the way it's reported out. You know, if you do a deep dive into the state of Delaware website, you find that where they get their data is indirect. It comes from the National Syndromic Surveillance Program. Now, the National Syndromic Surveillance Program is about a 15 to 20-year-old program that was set up to look at things like SARS and MERS and some of these other pandemics to try and establish a better access to real-time data. And the way they get that is they collect data from the medical examiner, they collect data from discharge paperwork from the hospital. The best data they get is at the end of the day, they get data from the emergency rooms, if the emergency rooms are capable of collecting the data and so inclined to send it along. The surveillance program, while it's really a step in the right direction, it chronically is minimum 48 hours out of date, and sometimes it's as much as 2 or 3 weeks out of date. So it's stale data. But that's where Delaware's data comes from. So
it's not accurate, is what you're saying.
I don't put much faith in it, and I think when you see the numbers change, I mean, it's you know, when you see the testing, which was somewhat rationed early on, suddenly opens up, and there are many more test kits out there. Well, guess what? If you test 1,000 more people, you're going to find a few more cases. So you know, the percentages are going down rather precipitously of people who actually get sick, and of course any death is not good, but what we're really seeing evolve here is the overarching death rate isn't going to be affected particularly by the coronavirus or by the infections from the coronavirus, but it's going to be affected in the long term by the fact that a lot of people are going to receive the wrong diagnosis, or a lot of people are going to be afraid to go to the hospital and get treated for fear of the virus. And so the death rate for the year may go up, but not directly because of coronavirus. I think the coronavirus particularly preys on the elderly. You know, and it's clearly slanted to people over 65, and even more slanted. I mean, it's 99%, I think, is over the age of 50, and something like 97% of the people who die have comorbid diseases. So these people probably weren't going to make it in the long term anyway. When I say long term, they probably weren't going to live 12 to 18 months from now. So yes, they're dying a little bit early, and that's a bit sad. I don't mean to be harsh, but that's not necessarily a reason to precipitate a whole slew of other problems around people not getting care for diseases that could be managed, and shutting down hospitals and shutting down the economy. I mean, we know for a fact that poverty is clearly strongly linked to mortality. I mean, if people are in poverty, they die, and they die earlier. And it's such an overwhelming linkage between poverty and disease and death that in many studies where you're trying to drill down into, say, I'll give you an example, asthma in children who grow up near power plants. When you study that, you have to necessarily remove from the data the people who are in poverty, because they skew the data so badly that they make all the rest of the data look like it's not statistically significant. That's how strong the link is between poverty and death. So in the big picture, we're doing some things here that aren't all that good. I think we're, you know, if you look at the techniques we're using, which we call mitigation, to flatten the curve, to mitigate the curve, to prevent the rush on the hospitals, you know, these were techniques that were developed 100 years ago. These techniques were developed to treat tuberculosis, to treat polio, to treat venereal disease. This new tracing contacts thing that's coming around, that is a technique that was developed to trace venereal disease.
So, doctor, because of time, so I want to kind of summarize, and then I want to get to questions, because people have been asking some questions, and I want to make sure that we get to these questions before our time is up. So we have
Sure.
skewed numbers. We have skewed numbers, and I assume it's the same thing with mortality numbers, right? The death rate, the death numbers, you would attribute to that to not being 100% accurate. That's why they died. Is that a true statement?
Yeah, I think they're being coded for obvious financial advantage, as if they're, but if you look at death before COVID, death after COVID, the numbers are about the same.
Okay.
So the overall rate hasn't really changed much. We're just attributing it to a different diagnosis code.
Okay. And so let's get to some questions, and I want to kind of wrap up as a summary of how do we move forward from here. I think it's really important. So we kind of set the plate. We have concerns, yet our economy is still being shut down, and is a problem for so many people. All right, and I'm going to do this based on the questions of when I got them. Okay, and so first question that I got was, I'm fairly healthy. I'm going to run through these pretty quick, doctor. Okay, I'm fairly healthy. This is from Barbara Barr, and she's asking, I'm fairly healthy, although I did have a joint replacement surgery in late December. I'm over 65. So my question is, when the state opens up, is it safe for me to go back to work?
Hi, Barbara.
What do you think?
She's a friend.
Oh, she is. Okay.
Yes, it is safe, but yeah, I know Barbara well.
Okay.
The answer to that question lies in whether or not you have successfully survived the disease and you have the antibodies. If you do have the antibodies, then you are perfectly safe to go out in the world. You don't need to wear a mask. You don't need to, you're not going to infect anybody, and you're not going to get it yourself. So that depends on the test. I went and got tested last Monday because I want to see my grandchildren, and unfortunately, I have not been exposed. Now that means I don't have to wear a mask because I'm not going to give it to anybody, but it does mean that I'm at risk. And so, yeah, I wouldn't go back in to work now for the risk to me.
Yeah. Well, unfortunately,
but Barbara's not at any particular.
Yeah. All right. Well, let me move on to some other questions here, and that is this has come up from Stephen Jacek, Jacek. Sorry, Stephen, if I got your last name wrong. Question is, have we seen the plateau in cases and deaths? What do you think? Doctor?
Yeah, I think in terms of Delaware, this is pretty much all over. Um,
Okay.
we may still see some residual people who don't survive on the ventilator because they have comorbid disease, and their glide path towards death has become significantly steeper than it otherwise would be. So some of those people aren't going to make it.
Okay.
But no, you're not going to see any further spikes. There's an excellent way of tracking this that's powered by KINSA in association with Oregon State University. They track forehead temperatures with their device, and their device automatically uploads the data in real time from every county in the United States. And starting about 3 to 4 weeks ago, 5 weeks ago, the trend of infection in Delaware began decreasing. The trend is now flat. It's over in Delaware. And the amount of abnormal disease is negligible.
That's all right. So we're going to come back to the political side, because what you're saying is not justifying these executive orders. Okay. I think are masks really effective? Can you take 30 seconds to talk about that real quick?
The masks prevent people who are talking from spreading their own droplets into the air. Masks don't work to protect you against other people. You breathe around the mask, and if the stuff is in the air around you, it's going to come right around the edges of the mask. You don't breathe through a mask. A mask is there to collect your spittle. That's why we use them in the operating room, not to protect ourselves. They're not effective. All they are is an outward sign of sensitivity to the issue, but they do not protect you whatsoever.
Okay. Let's see here. There are reports from New York about a potential compovation for youth. Is there any evidence this is related to COVID, or could it be something completely unrelated?
Yeah, there's a very, very, very rare, and we're talking about 1/100%
okay,
of children who have what's essentially an asthmatic response to the virus, and then have fatal blood clots or clots that cause strokes. It's a minuscule number of children, but it has been noted. One of the things about this virus that's a little bit unusual, but a little bit novel, is it tends to cause clotting. And so that precipitates strokes, heart attacks, pulmonary emboli, things like that. But that's usually in people who have other causes of that, like heart disease, vascular disease, cancer. Those are the people who are really vulnerable to that. So, for instance, I've talked to some people who just physicians who decided, I think I'm going to take a baby aspirin every day just for the hell of it.
Okay. All right, we've kind of touched about that, about a model. We seem to be, last part of this one is that we seem to be applying a one-size-fits-all approach to dealing with this pandemic. Is there a potential path where we can protect the vulnerable while not destroying the economy? Your take on that, Doctor?
Well, yeah, I think you need to follow what's been done in both Florida and Georgia. There has not been any further outbreak. There hasn't been a spike. They concentrated their treatment towards the vulnerable. And that was basically people in nursing homes who were very old and already sick. That's where you need to put your resources. You need to get the people who work in nursing homes some personal protection equipment, all the hand sanitizer and gloves you can find. You need to get the patients who do get sick in nursing homes out of there and get them into an ICU somewhere. But to do what New York State did, which was actually demand that people with coronavirus infections be put into the nursing home, was exactly the wrong thing to do.
Yeah. Okay. I thank you for sharing that. Here's the next question from John Riddell. I know you know him. And the question is this: Dr. Fauci has spread fear about hydrochloroquine, zinc antibiotic combination, even though frontline doctors in multiple countries have expressed that it is working, especially when administered early. Has Fauci's fear-driven solutions hurt treatment and the opening of our nation?
It's tough to fault Dr. Fauci as an epidemiologist, but he's not really treating patients. He's looking at population health, and he is correct that if you're dealing with NIH or the CDC, then you can't really make recommendations without doing blinded or double-blind prospective studies. And we don't have time for that.
Right.
We simply don't. The frontline doctors, to a person, are very enthusiastic about using azithromycin, which we know is Z-Pak, hydroxychloroquine, which we know is Plaquenil, and zinc. And there's this rapid collection of thousands of cases where the disease has been significantly shortened, and it's really helped patients quite a lot. Furthermore, try as we might, we cannot find any patient with autoimmune disease who is chronically on hydroxychloroquine, which is Plaquenil, and that would include patients with rheumatoid arthritis, lupus, psoriatic arthritis, these kinds of things. These patients are very vulnerable to disease because their immune system's compromised. None of them have gotten the infection. So that sort of tells you that hydroxychloroquine very likely is prophylactic against the infection, or certainly prophylactic against the massive response to the infection, which we call a cytokine storm, that is what is actually killing people. So Dr. Fauci is required to say he doesn't believe it yet, but that's just his little focal view, and he's following hard rules established in the small field of epidemiology. He's not following what the rest of the medical population is doing.
So with that being said, I know a good friend of mine that has, I can't mention the name, but he has been, he's got the virus, and he has been in ICU for, I think it's over 45 days, 45 days. And he was never offered, he actually asked for it early on, but he was told in Delaware, you can't get it. Is there truth to that statement there, doctor? Are there guidelines within Delaware that prevents
in Delaware
giving it to their patient here in Delaware?
Very early, my own personal physician tried to give hydroxychloroquine to his daughter, who's an insulin-dependent diabetic. So he wrote her a prescription. She needs it. She really does need it. And because he wrote his daughter, who fits all the criterion, this prescription, the head of the Delaware's head of pharmacy oversight called him up and threatened to pull his license for prescribing it. So Delaware has a singularly, well, because Delaware has a singularly crazy bias against this very inexpensive and very, very safe medication and they're trying to bully people into not prescribing it. You know, hydroxychloroquine, quinine, if you will, was standard issue to all of the British soldiers when the United Kingdom was colonizing India. You know, it's been, I mean, every soldier was made to take it. It was like taking your vitamin.
Yeah.
It has a 200-year history of safety.
Well,
I don't get it.
And you know, I want to get to some more of these questions. Another question is the locking down of our society as harmful or more harmful than opening it up?
Oh, I think it's unquestionably more harmful than opening it up. I think you look at the examples of opening up of Georgia and Florida, and it's been just great. I mean, nothing bad has happened.
So
I mean, all of these doom and gloom things are just.
Go ahead, doctor.
I'm sorry. Go ahead.
No, I was just going to say. So why are we?
I did the doom and gloom predictions. I think you really want my blunt opinion.
Yeah. Yeah.
I think what has happened is that there is a combative political climate that is over that is everywhere, and this is just another crisis that is being taken advantage of to the overall detriment of the country. I think people have gone from seeing this as something we need to work together on to seeing it as something of a weapon with which to punish their opponents.
So you think it's political? Bottom line.
I think it is now. I don't think it started out that way, but I think it's overtly political now, and I think our governor in particular has a very close association with the governor of New York and a very close association with the presumptive candidate for president. And I don't think he's going to do anything without doing what they want.
And how do we overcome that? I mean, as Delawareans, we're stuck at home. Many of us are still, quote unquote, still considered non-essential. How do we overcome this? What do you suggest?
Well, it's like that old movie where you go to the window, open the window, stick your head out, and said, "I'm mad as hell, and I'm not going to take it anymore."
Yeah. So we got to speak up, I guess is what you're saying, right? As Delawareans, we need to speak up, I guess is what you're saying.
Yeah, I think it's time at the bare minimum to speak up. I think it's time, and you see it everywhere. People are getting out and about. They're fed up with it. They're wearing their masks and they're trying to be good, but I think people are just fed up with it.
So
they want to get back to normal life.
I'm trying to figure out how to, let's see here, where is she? Forgive me, you all, because I'm still trying to figure out how to do this. I want to unmute Gina Hall. Gina, I know I see you. I'm just trying to figure out how to unmute you, so forgive me. And let's see here, how do we do this?
It should be that little red button down in the lower left corner by her picture.
Yeah, I'm just trying to find her picture actually. So that's probably what I'm trying to do here. All right, let's see here. Let's do this. Here we go. All right, Gina, I'm going to unmute you. Go for it. Go for it, Gina.
I don't know why you're picking me, but
go for it.
So, I mean, I hear everything that the doctor is saying, and I completely agree. We're all doing everything that we can to be safe, but as a small business owner in Delaware, we are being affected big time. And it's just not my business, it's every other business. I just believe in the fact that if you're compromised, you're not feeling safe, that you should stay home, take the precautions, and do what you need to do to be able to stay safe. But there's 1,000 other businesses out there that are not going to survive this season by not being open or being open at 20% capacity. That's my concern. I'm concerned for myself, my business, the other businesses that I know, my instructors, my staff. This is a financial issue. I mean, not so much a health issue. Like I said, I mean, you have to weigh your options here as far as what works for you. I don't like wearing masks. I mean, I feel like I live in another country right now. This is not normal. And I'm not going to accept this as being a new normal.
Doctor, any thoughts?
Well, Gina puts a human face on this, and that's really what you have to do, because people glaze over when you give them the hard numbers, but they do respond to human stories, and the story she's telling is just extremely true and valid for so many people. There are tons of businesses that just have to get back out there and have to interact. At some point or another, the economic problem becomes a health problem. So if you can get out there and tell your human story and say, listen, I'm going to have to let my people go. I'm not going to be able to, my business is falling apart. I can't afford to stay in business.
So my business is a gym, okay, which actually is a benefit to health.
Yeah.
And
That's right.
I have instructors who are very social people. They need that contact. I mean, that's what they strive for, and that's what they're for, to be able to see other people's faces and interact. So, yeah, I know that the steps that we've taken for our gym have been far and beyond what any grocery store or pharmacy or bank or whatever you want to call it has taken as far as being safe and going forward. But that social interaction is very important. And I'm not necessarily that person, but I have instructors who are on their 2.5 month of not having interaction with the people that they love. And it's taking an emotional toll on them. Mm-hmm. Not to mention a financial toll. I mean,
so here's the thought, because we've got some more people, and I just so you know, okay. Doctor, are you able to hang with us a little longer than 8? Are you okay with your schedule? Are you?
I'm totally fine. I wanted to tell Gina, one person suggested to me earlier today that you should, if you want to hold, say a yoga class, you just have to do it at Home Depot.
Yeah. It's sad, but very true. Doctor, look, we're seeing this, and Gene, I don't know, before I jump on to the, VJ, you're going to be next if you're listening to this. But look, I know some businesses that are opening up despite what their executive orders are saying. And nobody can say or suggest or do that, but I know it's happening. And I think we may see more of that as people's frustration is not being listened to, is not being listened to. So, it's a tough one. So Gina, thanks for your question, hon. All right, VJ, you're up next, buddy. All right, VJ, go ahead.
Hi.
Okay.
Yeah, that was a valuable insights, Chris, from you, and I'm glad that I was able to follow you closely there. My question is there anything that we can do to improve my immunity apart from what the regular suggestions like vitamin D, vitamin C, zinc? Other than that, will there be any additional flu shots that we take and that would improve 1 degree of our immunity towards COVID?
I don't know that there's anything that's going to make you completely immune to COVID, including a vaccine. Every COVID, most COVID infections, most coronavirus infections are what we would normally call the common cold. And as you know, there is no vaccine for the common cold. The coronavirus is very slippery. It can change very, very quickly. So the only way you're going to become immune to this one is by getting it. But that does in fact work. It does seem that people who take zinc, vitamin C, quinine seem to do better. But certainly if you get sick, azithromycin, which is known as Z-Pak, really shortens the disease duration and the symptoms lessen quite substantially. So those are basically what we have in our tool chest at this point.
Okay.
Other than the things that we talked about, social distancing, not kissing everybody you meet, not shaking hands, bumping elbows, and it's kind of staying away from sick people.
There you go. VJ, thank you for your question. We're going to move on to the next person here. Lisa, I think you're with us. Let me find you and then unmute you. Okay, Lisa, go ahead. You're all set.
Hi, Dr. Cassells. This is Lisa McCulley from Delawareans Against Excessive Quarantine. And a lot of our group is talking a lot about contact tracing, and I really would love to just get a little bit deeper to expose some things about contact tracing that doesn't make sense medically or scientifically. So my question is this: does contact tracing even make sense scientifically at this juncture? Isn't it late in the game? Typically, it's done earlier with communicable diseases like tuberculosis and not with something like a coronavirus. Am I correct in saying that? And doesn't it seem more like a money grab and scare tactics to control?
That's a very good question. Contact tracing, although it was begun, you're correct, in the era of tuberculosis, which is where we also began to quarantine people, and we built these sanatoriums all over the country. But contact tracing really has its roots in tracking down sexual partners, and so we used it to fight venereal disease and gonorrhea. And before we would let anybody get treated for either venereal disease or gonorrhea, we made them give us the list of people that they'd had sexual contact with, and then we went to those people and got the list of people they'd had sexual contact with, yada yada yada. And it was a very effective technique. But that's also a circumstance where most people pretty much are aware of who they've had sex with, and so it was a doable thing. It wasn't really doable with tuberculosis. It's not doable at all for the coronavirus. It's simply, you're not going to be able to track it. There is a financial element to it because they're baking it into the software of the phones to be able to do this. So there's going to be some money made on the contact tracing. I think it's a fool's errand. I think it's a power grab, and I'm very disheartened to see it become the darling of the treatment model, when I just don't think it has much benefit, and it has a lot of risk when it comes down to simple personal freedoms.
Yes. One more quick question, if you don't mind.
Sure.
One of our group members just got out of quarantine for 14 days because she tested positive, and she was given a form from the Delaware Health and Social Services, a Delaware isolation instructions that basically says that she's got to waive her rights. Have you seen this form, and what is your take on that?
Yeah, it's a pretty scary form, and it was mistakenly given to somebody who's tested negative, and they sent it out saying that the person waived their rights. They waived their right to have a hearing in court. They waived their right to having legal representation. That form is draconian. I cannot imagine it passing the legal smell test. I can't imagine it getting by any legal review.
Thank you.
Yeah, I thank you, Lisa, very, very much. So I appreciate that. And I think Sandy, looks like Sandy, I think you're still here. Sandy Caton, I think you may have a question here, it looks like. Go ahead, Sandy, if you're still with us.
Oh, Sandy Kane?
Yeah.
Yeah, hi. A question about can an asymptomatic person spread the disease? And do we need to get tested, or how do you get all these different tests and stuff? You just lie and say you've got something and you've got symptoms, or what does a normie do to just find out what's going on?
It's a good question. If you're in the Palo Alto area around Stanford University, you simply go to a grocery store or anywhere like that. Stanford is out there testing everybody they can get their hands on because they got a finger stick test. And now when I got tested earlier this week, they drew a vial of blood out of me, and that's much more invasive. And of course, it cost me $115 at Quest. But I could write the prescription for myself. I think very soon we're going to have widespread antibody tests, and that's going to determine who is safe to go back to work. So I would expect, I mean, if the world were a rational place, what you would do is you would open up the workplace to anybody who's already had the disease because they've got immunity now, and you'd open up the workplace to anybody who tested positive for the antibodies. That would be the rational way to open everything up. And then you just give everybody the antibody test, not the test for the virus. The test for the virus doesn't add to your decision-making much at all, because if you have a positive test for the virus, which is the nasal swab, guess what? You have to go quarantine for 14 days until you're over it. If you have a negative test for the nasal swab, guess what? You shouldn't be around other people because you might get the disease. So it doesn't help your decision making. The algorithm all goes to the same place. But in the best of all worlds, we would rapidly do the blood test looking for the antibodies. We test everybody who wants to go back to work. That would be your ticket. That would be your get out of jail free card to go back to work, to get out there. You wouldn't have to wear a mask. You'd be considered safe. But I don't see that happening with any great rapidity. I think holding out for a vaccine, as I said before, is a fool's errand. I don't think that's going to be effective or any time within the next year or two. And even if they do develop it, I don't think it's going to work very well.
So you don't think that the antibody test generally is going to be available anytime soon either?
I think it's rapidly going to necessarily be available. They're going to have to make it available because it's the only way to make the argument that we can open up the economy again, and we must open up the economy. We can't not do that.
Can doctors prescribe that we get this test?
Yes.
Yes. Okay.
You can call your doctor, and he can call in that test to LabCorp, Quest, the hospital, anywhere. You can go to testing points and specifically request. You can go to the blood bank and say, if you test me for the antibody, I'll give you some blood.
Yeah. Win-win.
All right.
Yeah.
Danny, thank you for your question. Really appreciate it.
Thank
We're going to move on to Deborah Mitchell. I think you're still here with us. And at least I think you are. Can you hear us, Deborah? Maybe not.
Yeah, I hear. Can you hear me?
Okay, perfect. All right, you're up, Deborah.
No, I just had I wanted him to clarify about repeating twice that once you've had it, you're immune to getting it again. When I know someone who actually got it twice, and after the second diagnosis died within 3 days.
Yeah, it's not that they had the virus twice.
He had it in March, he was cleared negative, and then he got it 2 weeks ago.
Well, what you're seeing is this adverse lung reaction, which goes by a number of different names. It's a late effect of the virus. It basically causes a respiratory distress syndrome sometime fairly late on in the process. It's not actually a reinfection with the virus. But since the first part of the virus wasn't that severe, that patient survived it, but then the late effect kicks in, and that may not have been survivable for him. I'll give you an example. Some time ago, I began to get some seasonal allergies, and the allergies ultimately evolved into kind of an intense respiratory cough that wouldn't go away for weeks. it's not actually the primary disease. It's my body reacting to it. And so, that does happen. In the case of this coronavirus, the late effect, number one, is an overwhelming of the respiratory system of the lungs in some people who are predisposed to that. And then the other effect, which is somewhat late, is this propensity to clot. And when you get those clots, that can cause heart attack and shut down your ability to breathe, something called a pulmonary embolism. And nobody's quite sure why the virus does that, but it's probably what is responsible for this mistaken notion that you can actually get the infection twice.
So real quick, and thank you. March, he was diagnosed as positive, quarantine. At that time, he would have been infectious to someone who got close enough to him. Then he was cleared, and then 2 months later, he gets it supposedly again. But what about when we go back into our schools or we go back into the gym? This second stage that you're talking about, are we contagious or we're not?
No, they're not. Those patients are not contagious.
Okay, thank you.
Yeah.
All right. Thank you so much. Marilyn, I think you're going to come up next here. If you're still with me, I'm not sure if you are. Maybe, I think she emailed us, but I'm not seeing her. All right, so let me keep going down the list here. I think Barb Buckenvidge. Sorry, Barb. I know I'm messing it up. Barb, are you with me?
Yeah. Hi, it's Steve.
Oh, okay.
the lesser half. Yeah. Thanks for letting us in. I think my question was more around contact tracing and the whole question of whether it's the right tool to use today for what we're facing. Dr. Casscells, I think, addressed that. I am, and we are concerned about the documents that you do receive as a result of this contact tracing. It looks like a charging document rather than guidance and support. Delaware has stated, at least Carney's office has stated, that they want to conduct about 80,000 tests per month. And my question is, it's like, do we have any information about how they plan to do that? Are they going to harden off areas and just, go door to door and demand that you take the test? And, what's that all about? Because again, it just seems like that would have been useful when we had a lot of questions back in February when we were wondering about the population. Now that we have a set of identifiable characteristics for who are most at risk, whether you're testing or you're looking at patient profiles, you get to the same point, which is let's dedicate resources to the high risk patients and those that are most at risk. And I'm sure lots of Delawareans would step up to support long-term care facilities, nursing home, and support those who are genuinely at risk. Let the rest of us just get back to our lives. So.
I think you're absolutely right. That's where we should be directing our efforts is the vulnerable population. We know who they are. We know where they are. We've found that open air and getting outside is actually helpful. Being closed up inside your house is actually not helpful. So this quarantining, this shutting everybody down and staying home is actually making it worse. We put out a number of these kinds of questions that you're sort of circling around in a Freedom of Information request yesterday to the governor's office, and asked many of these questions about the plan and what the real data shows. And within 3 minutes of that email request, Freedom of Information Act request to the governor's office, we were told by the governor's chief of staff that there would be no honoring of Freedom of Information requests until the emergency stay in place order had been lifted for at least 15 days. In other words, basically the governor's office says, we're not telling you anything until 15 days after we decide
To
the
take away
emergency
liberties.
order is over with.
Yeah,
So
after
they're
we deprive you of
stonewalling.
your liberties, then we'll go ahead and tell you.
Right, right. They're stonewalling completely, absolutely.
Yeah.
And I'm not opposed to testing. I don't want to come across that way, but when you look at that document, and somebody, I think Lisa may have referenced it earlier, around, you're waiving your rights, and they're citing all these statutes and things in there. And it's like, wait a minute, I thought this was to help the population and to help us as citizens conduct ourselves in a way that helps our neighbors and our communities. And most of us have shown that we're willing to do that. And then you turn around and it seems it's more punitive in nature. And then it makes me think, it's like, do I want to be on a government list, or do I want to be in somebody's register, have my liberty taken away from me, based on a test, where if I'm negative today, I could be positive tomorrow. We've talked a little bit about that, and it just seems like, what's really going on here? But then how do we as citizens come together as a community to say, we want to help each other, and of course we want to beat this, but we think the way that you're going about this has significant, let me be kind and say, unintended consequences, and we have a different plan to do this. I think, Rob, that's what we're looking for, potentially elected officials, to help us organize that in a cogent way that where the message can be heard.
When you think about it, historically, when people have become sick with contagious diseases, we have quarantined the sick people.
Right.
Why in heaven's name are we quarantining the well people? It's absolutely backwards. I saw a question pop up earlier that I wanted to address very quickly about the type of antibody test. There are several different antibody tests out there. I think the one that's going to carry the day is a little finger stick like diabetics do for their sugar. But there are 2 or 3 ones out there. One of them is lousy. The Food and Drug Administration has recently okayed 2 others. But it's true, there are different antibody tests out there.
Well, thank you very much, Barb. I know it's not really Barb, but the name is Barb. So yeah, great question. And I appreciate you for being part of this. So, hey, Stacy A., I'm going to come to you next. And let's see here if we can get you to unmute. I think you are now.
Mm-hmm.
Yep. Okay, go ahead.
Hi, everybody. So my questions, I lost my chat because I had to leave, but my questions really earlier were, I know we're talking about all these things that, you can do and you can avoid. And I think all of us in this Zoom meeting are in the same mindset. So my big thing is, what are we supposed to do with a governor who isn't in this mindset? What do we do? Move to Georgia and Florida where everything is great? And then my other question along with that is the fact that we're nowhere near phase 1 of this, and we have to social distance, and we're going to ease into this and ease into this. Where does that leave places like schools where you have many hundreds of kids who it's impossible to social distance? What are we going to tempt them every day? We got to have them have masks, all this stuff. How are we even going to, the way I look at it is we are not even going to start in the fall because of the way the governor is going so slowly. There's no way, unless they come out and say that all of a sudden their data was invalid and unreliable, that we're going to be able to do this. And I just am wondering what your thoughts are on that.
I don't want to be the one to recommend social disobedience, although I did some of that back in the 60s and 70s. But at some point or another, when the rules that you're being forced to live by become so draconian, there are really only 2 paths left for you. One is break the rules. The other is, curiously, something that Abraham Lincoln suggested. He said when the rules become something you can't possibly live with or follow, then make every conceivable effort to follow them as closely as you possibly can, and it will destroy the rules themselves.
Right.
And so, I'm not sure which of those answers is correct, but I think the first step is to get the message out, to tell people that this is bordering on insanity.
Right. And well, the unfortunate thing is, how do you get, because everybody's so afraid, so how do you get the districts and the superintendents to agree and say, okay, we're going to open the schools, we're going to do this, without having, and say, hey, you want to send your kid? Send your kid. You don't? Maybe parents would want to send them now, but I just don't see, with all the fear-based stuff going on, how we can get out of this, and unless we have a governor who's going to change where he's going with this.
I don't think our governor is capable of quelling the panic that he has infected us with. I think it's all about the panic. People are scared. They didn't have to be scared. They could have been reassured, and none of this would have happened. But I don't think that's in our governor's skill set to actually lead us out of the panic.
Agreed. So we're screwed, basically.
No, I think we just begin to go back to our regular lives, whether they like it or not.
I think that's pretty profound statement right there. Stacy, did you any last minute questions you may have for the doctor?
No, thank you.
Well, thanks for being part of this. We're learning. I appreciate y'all's patience on this technology thing, and I had questions emailed to me, as you know, along with questions here in the chat. So we're learning how to navigate this, and also, of course, keep an eye on the clock and trying to keep everybody happy and engaged. So we are learning. It's the first one. Let's hear. Is there anything else that I've missed here? Can you discuss? So here, Doreen, I'm going to have you come up next. I'm going to find you, Doreen, if you're still with us. You are, and I'm going to unmute you. Okay, Doreen, go ahead.
Yeah, I just was wondering about the testing. I really believe that we're going down a rabbit hole with this testing, and that it's not accurate. And this PCR test was never designed to be used as a diagnostic tool.
It's true that I don't think the PCR is the test to find the viral load. It's just to say whether you're infected or not. It wasn't. You're right. It wasn't designed for that. I don't put any faith in that test either, and I don't see the value of it.
So why are we insisting on having this test before we can go back to our normal life?
I don't think the PCR test is looking for the virus itself. The test I'm recommending is the antibody test, which,
no, I understand
which says,
that, yeah.
And I don't see the point of the PCR test other than financial.
But that's the test that people are lining up to get, and that's the test that's in the paper every day saying so many more people are positive.
Mm-hmm.
I know.
And if I can chime on that one, Doctor, I think I think it's also that's the political phase, is it not? I mean, isn't that kind of really their goal, is to keep the numbers increased so they can keep the fear and keep the hold on we the people? I mean, is that not it? What do you think, Doctor? I mean, is that not what the goal is?
I'm far from an astute politician, Rob, as you well know.
No.
But I think I can't find another rationale for doing it other than to buff up the numbers.
The financial gain and fear and political gain. I think those that are doing this feel that somehow I think it's going to help them come November and perhaps blame the economy on our president. So,
well, if you think about it, Delaware was heading towards a cataclysmic budget problem largely with their healthcare costs and poor outcomes and so forth. Now, if Delaware becomes insolvent, then is there possibly a request from Delaware for a big bailout from the federal government? That would be one way out of Delaware's impending budgetary crisis.
So maybe that's what they're hoping for. So Doreen, did we cover everything? I think we're good with you.
Yeah, and I guess the doctor feels that the antibody tests are actually accurate, because I had questions about that, because my understanding was that with the antibody tests that there was no proof that there was immunity, because they weren't, you have to quantify the antibodies, and then there's no proof that you're actually immune, or for how long you would be immune.
Yeah, the early tests, the first test that was recommended by the CDC, the antibody test, was not a good test, and the first PCR test from the CDC was inaccurate. It had a lot of false positives and false negatives. The new antibody test that has just been approved by the Food and Drug Administration on a fast track. It just got approved within the last week or so, 2 weeks maybe, is the one I referenced that Stanford University is using, and it's very, very, very effective and very accurate. But you're right. There were a couple stumbles out of the blocks on getting a hold of that. Largely, that was the case because we had a hard time getting the DNA samples and sequencing out of China. They pretty much held them back from us, and so we started a bit late on this. If we'd been able to start back in October, November, a lot of this would have already been out there, but it got kind of a late start on the antibody test.
Yeah, well, Doreen, thank you so much for being a part of the conversation and speaking up.
Yeah, thank you.
So thank you very much for your patience. So doctor, looking at the clock, we've already gone 25 more minutes than what I had originally planned for, but I'm thinking everybody's okay with that. But in these last few minutes, we need to talk about how in the hell do we get out of this? Because the governor, in my mind, continues to restrict. And I got to tell you, my wife and I went up to Walmart today. We went up to Rehoboth, and she wanted to go to Michael's, which is in the same shopping center. And Michael's, along with some other stores, right, are technically open, but there's no cars there because it's only curbside service. So who in the heck is going to go to Michael's to get a curbside service, right, for their stuff? And then right across the parking lot is a jam-packed Walmart. Okay, so it's okay to go there with no problem, but we can't go to Michael's. Where's the sanity in this? And let's talk political. Okay, because I know you got a lot to talk about on that real quick. Give it away from your heart.
Are you asking me?
I am, doctor. Yeah.
Oh, I'm furious with Delaware's leadership and management of this. This is a 2-week thing that could have been over and done with. And as I said, I went back. Because so many things have changed so rapidly, I went back to what I wrote and was published through CRI on March 15th, and I wouldn't change a word of it. You just need to do some normal, safe things, and this would have been a non-event. It's been hyped. It's been taken advantage of. It's being wielded like a club. It's been very, very badly managed in this state.
So how do we move forward? I mean, is it lawsuits? Is it lawsuits against the governor? Is it we the people stand up and protest as some have, and I think more are coming? Where do you see how do we navigate and get through this so we can get back to our lives and controlling our financial destinies, if you would, versus this draconian dictatorship that's been going on with our governor?
I think en masse, we all go back to work. There's nothing they can do about it.
So we should have a get back to work day.
Yep, just go back to work.
Oh, reopen Delaware Day, I guess, or open up Delaware Day.
Yep.
And that's
Yep.
what we do. And I've got to tell you, I'm shocked at the
Yeah.
at the retailers and the restaurants, especially here at the beach area. We're heading into the season. They've been by and large silent. By and large, has been very silent, as have many elected officials in Delaware. Many elected officials, I know some have been doing some things behind the scenes, as I speak to them often, but there's very few that have been out very public and voicing their concerns publicly in mass, or even at some of these protests. And I'm not so sure why. What do you think?
My disappointment is so thorough at this point, Rob. It's hard to make it any more disappointing. I'm very unhappy with how it's been managed on many levels.
Well, I mean, so we got about a minute or so. So on that note, leave us on a positive note. So get back to work day, a legal path. And what else can you share with us? And how can we move forward from here as citizens?
I would say, if you're over 65, you have a couple of health problems, then maybe just wait until it warms up just a little bit more, another week or two, before you get back out there. If you don't have any health problems, if you just think about not shaking hands, get out there. Just get out there, because the power lies in going back to a normal life. It's amazing. My wife and I go to church every Sunday. There's nobody there. We have the church to ourselves. I want to see people back in church. I mean, it's a lovely time to meditate, but none of my fellow parishioners show up. On a couple of occasions, we're the only car in the parking lot. I don't know. I think you just have to shake your head and use some common sense and get back to the life you want, and just ignore these idiots.
Well, there you have it. Ignore these idiots. I think that's a great quote to leave on. So, Doctor, we appreciate you, and the entire group and audience. I don't know exactly how many people were. We had a certain cap, and I think we were right at that cap on the registrations. And this is the first one. We're going to do more. I'm learning, and I apologize. We didn't get to everybody's questions. We're trying to learn how to navigate this stuff. But I think the heart is there. We want to do the right thing and allow Delawareans to speak up and voice their opinion. And I think that's what we have to do. And that's really was the whole purpose of this. And Doctor, thank you so very much for your leadership, I think, in our state, and for your willingness to come and share to the audience. And again, this is well beyond the people that have been part of the Zoom. This has been going live on Facebook. So I know there's hundreds, if not thousands, of people that have been watching this during the duration. So again, we appreciate you. And any last minute thoughts, or Doctor?
Rob, I think you're doing great work here. It's a fabulous idea, and I very, very much appreciate the opportunity and appreciate everybody who tuned in with such great questions. Thank you all.
And if anybody's got any last minute questions, email them to me and we'll forward them to the doctor and then get them answered. Doctor, would you be agreeable to that?
Yep, I'll do my best.
Okay, awesome. Hey, everybody, it's been fun. It's been real. And let's get back out there and stay vocal, and let's turn the state back around. Okay, God bless everybody. Thanks for being part of this. Appreciate it. Bye-bye.